Welcome everyone to our continuing education activity, Weight Management and Community Health, Bridging Systems and Care Coordination, brought to you by Weitzman Institute and the France Foundation. Our expert faculty includes myself, Dr. Mandeep Brar, clinical endocrinologist in Phoenix, Arizona, Dr. Joy Maccabee, family physician, obesity specialist, Holly Bryant, registered dietitian, and Dr. Don Graham, associate professor at Ohio University. Our learning objectives are to outline factors which impact obesity risk and outcomes, identify strategies to address barriers in initiating discussions of weight with patients with obesity in the community health setting, examine the different therapeutic strategies for managing patients with obesity, and describe effective multi and interdisciplinary care strategies to manage the care of patients with obesity in the community health setting. And now on to our didactic lecture, What We Know About Obesity. Overview of obesity and overweight. Overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. A body mass index greater than 25 is considered overweight, and greater than 30 is considered obese. Overweight and obesity raise the risk of cardiovascular disease, including coronary artery disease, type 2 diabetes, asthma, high cholesterol, osteoarthritis, high blood pressure, sleep apnea, and certain types of cancers. As we can see on the graphic on the right-hand side of the screen, BMI is calculated using height and weight. Obesity demographics. According to 2020 data, state-level obesity rates vary considerably from a low of 24.2% in the state of Colorado to a high of 39.7% in Mississippi, as we can see in the graphic on the right-hand side. We have increasing obesity rates in the United States since the early 2000s, as we can see on the graphic at the bottom of the screen. The blue bar are states with obesity rates between 30 and 35%. And the red bar we start to see in 2013 are states with an obesity rate over 35%. And as the years progress to 2020, we continually see an increase in number of states that have an adult obesity rate of greater than 35%. The causes of obesity and overweight are multifactorial, but they can be divided into grossly 6 groups: lifestyle, genetics, comorbidities, medications, environmental factors, and cultural norms. These can be divided into modifiable and non-modifiable risk factors, and some of these risk factors actually overlap. Modifiable environmental and lifestyle factors associated with obesity and being overweight include the following: obesogenic chemicals such as BPA and pesticides, dietary factors such as excess food intake, energy imbalance, high fat diet, or poor nutritional choices, physical activity, a sedentary lifestyle or lack of consistent exercise, sleep deprivation, insomnia, or other sleep disturbances like sleep apnea, alcohol intake, chronic alcohol intake, alcoholism, a high social intake of alcohol as high in calories as well. Weight loss interventions can also negatively impact patients over a long period of time if they are very extreme in nature, such as extreme exercise regimens or a very hypocaloric diet. Epigenetic drugs, semaglutide and liraglutide, for example, can help improve weight loss goals. The genetics of obesity can be divided into syndromic forms and non-syndromic forms. Individual genetics are non-modifiable risk factors that influence both weight gain and weight loss experiences of patients. In regards to syndromic forms, that can be further subdivided into chromosomal rearrangements or pleiotropic changes. An example of chromosomal rearrangements would be Prader-Willi syndrome. In regards to pleiotropic, an example would be Fragile X syndrome or Cohen syndrome and BBS syndrome. Non-syndromic forms can be divided into two, monogenic obesity and polygenic obesity, which further have their impact from various downstream molecular signaling patterns. Molecular pathways impacted by obesity are very complicated and overlap between anti-obesity and pro-obesity behaviors of the body. There are many different pathways that can affect both of these events. So in regards to anti-obesity, as we can see on the graphic on the right-hand side, the three main drivers are hypophagia, thermogenesis, and lipolysis. In regards to pro-obesity, we can grossly categorize it into three different categories: adipose tissue inflammation, insulin resistance, and adipogenesis. As you can see on the left and the right-hand side of those two columns, we have overlapping molecular pathways which influence both of these with a long-term intent of creating a balance in the human body, but that is not always seen due to modifiable factors and epigenetic changes. Briefly, we can review the three most common pathways: MAP kinase pathway, which regulates appetite, adipogenesis, glucose homeostasis, and thermogenesis. The PI3K and AKT pathway regulate appetite, insulin signaling, cell growth, and proliferation. The JAK-STAT pathway, downstream mediator of various cytokines, hormones, and growth factors, as three examples of the many that we have listed here. Obesity leads to a hyperinflammatory state. It's associated with a higher prevalence of comorbidities. Severe obesity is associated with an even greater risk than lower degrees of BMI within the obese range. Obesity can increase inflammatory mediators like TNF alpha, interleukin 6, which lead to a hyperinflammatory state. This hyperinflammatory state is thought to be a key driver for cardiovascular disease and other comorbidities associated with excess body weight in the obese range. Prevalence of concurrent comorbidities with obesity can be seen. Most commonly, 75% of patients have a concurrent diagnosis of hypertension. Patients also have a very high rate, more than 90%, of type 2 diabetes, as well as 72% of those have GERD. 50 to 75% will have a steatosis of the liver. 60% can have osteoporosis. The range at which people can have associated PCOS is very wide at this point in time, but that data will be clarified. Current quotes are anywhere between 38 and 88%. Patients also have an association of obstructive sleep apnea about 45% of the time, showing you the important impact of obesity on other chronic issues. Social determinants of health are the conditions in which people are born, live, learn, work, and play, impacting their health, functioning, and quality of life. Some examples of social determinants of health include access to housing and transportation, racism, discrimination, violence, education, job opportunities, and income, access to healthy foods and exercise, pollution levels, language, literacy skills, as well as numeracy issues as well. Social determinants of health can negatively impact patients' understanding of a medical condition they carry, the interventions that are required. They may also limit their ability to apply interventions, even if they want to, as well as their ability to trust and seek out help from the medical community. Impact of social determinants of health on obesity specifically are very complicated. Historical, social, economic, physical, and policy contexts, legal risks and protections, institutional racism and discrimination, economics, employment and occupation, education, neighborhood and location all feed into systemic effects on daily life and choices. Food access, affordability, and appeal, food and nutrition literacy, options for safe and affordable recreation, transportation access to then be able to further access recreation as well as access to fresh vegetables and groceries are limited. Exposure to violence or concern of safety when traveling to reach better food sources or safer places to exercise. Activity norms of the community, chronic stress, sleep health, and food security all then further feed into weight control and related contextual outcomes and effects on the specific individual, such as food intake, dietary quality, child feeding and parenting, physical activity, sedentary behavior, excess weight gain, ability to lose weight, ability to maintain weight and weight loss, body composition, and fitness levels in regards to fat mass versus muscle mass. So, as you can see, social determinants of health are very complicated, but do eventually trickle down and affect the individual patient that was seeking care in regards to their medical health. We also see an impact of race on obesity. It's very important to understand and know that these are actual issues that are affecting an individual that comes into a clinic seeking help. So, for example, Black women have the highest obesity rate amongst US adults at approximately 57%. Asians have higher health risks at lower BMIs, increasing their risk of type 2 diabetes. About 40% of Asians with diabetes are undiagnosed, according to some estimates. The BMI cutoff for Asians to be labeled as overweight is actually greater than 23 versus other populations where the cutoff is 25. National surveys often lack health data on Native Americans, Alaskan Native adults as well. And we can see down at the bottom the graphic showing select demographics in the year 2017 to 2018, showing the percent of obesity in these subgroups, and most averaging around 40% for the general population. And we can see some populations are far above 40%, and some are estimated as being below, most likely due to an underestimation in those populations of a true diagnosis of overweight and obesity. Screening guideline recommendations. Here we have two recommendations, one from the US Task Force and one from the American College of Cardiology and American Heart Association. As you can see, the recommendations for screening all adults for obesity includes the utilization of body mass index of 30 or higher, with or without the use of a waist circumference, which can be helpful in certain populations, as we discussed earlier, such as Asian populations. Obesity screening overview. Obesity screenings typically occur as part of routine checkups that include physical exams and should be part of every visit, even if the patient is not specifically visiting clinic for that reason. As part of the appointment overview, the clinicians should review medical history, including a detailed history of family and comorbidities. So, for example, family history is very important, especially if the patient says, I am more overweight than the rest of my family, or I gain weight in the same way as the rest of my family. These questions and answers can provide clues as to which factors are most impactful in this patient's weight gain thus far and will be most impactful in their weight loss journey. Same can be said for comorbidities. If a patient is suffering from lower back pain or osteoarthritis of the knees, that will definitely impact our exercise and activity-based recommendations for this patient to be successful. Also want to review current medications for any that may be inducing weight gain or inducing a change in their metabolic status, as well as their personal habits, such as diet, stress, exercise, and sleep quality. The intent of this is to get a baseline understanding of the patient as a whole. Some blood tests that can be helpful include cholesterol panel, hemoglobin A1C, and a TSH. Screening tools that we can use to assess a patient for overweight and obesity include BMI, waist circumference, waist to hip ratio, skin fold measurements, and BIA, bioelectrical impedance analysis. Body mass index is the most utilized and generally accepted as a first step to determine the degree of overweight and obesity in patients. As you can see on the right-hand side, the image shows the varying ranges of BMI, normal being between 18.5 and 25. 25 and above is associated with overweight, obesity as the number increases. It is a practical way in clinic we can assess the potential for the patient to require weight loss or make lifestyle and behavior modifications. It is also useful in determining increased risk for other morbidities and mortalities on a population level. Overweight and obesity can be classified by BMI, as we previously discussed, but we can have additive information from a waist circumference, which can be associated with disease risk. So as we can see in this graph below, a waist circumference in men of less than 40 inches or in women of less than 35 inches, if overlapped with a BMI between 30 and 34.9, which is obesity, can be inferred as a high risk for other morbidity and mortality issues. If the patient is a male and has a waist circumference of greater than 40 inches, or a woman with a waist circumference greater than 35 inches, falling in the same BMI range between 30 and 34.9 can then be assessed as being very high risk for other comorbidities such as type 2 diabetes, hyperlipidemia, etc. So waist circumference can be an additive physical exam to our baseline BMI. BMI can have some limitations, as is commonly discussed amongst patients. It may not correctly assess our differences in bone weight, our muscle mass, may also not take into consideration specifics for genetics and race, and it is not an exact one-to-one relationship to percent body fat. But it is currently the most useful vital sign to assess overweight and obesity.
Thanks, Dr. Brar. I'm Joy Mockbee. I'm a family physician and I work at El Rio Health Center in Tucson, Arizona. I've been practicing obesity medicine since 2014 and became board certified in 2015. And I've had the real privilege of being able to work with community health center populations for my entire career. Today, I'm going to talk about treating obesity. And just to get started, I want us to think about why do we do this work? Why are we treating weight? And why are we working so hard with patients in order to improve this metric? It's really because obesity is not just a cosmetic concern and it's not just an isolated condition. It really is a driving factor for so many other chronic disease states. And we know that by treating obesity, we can actually improve a multitude of health outcomes. This slide gives a general overview. There are many other conditions that are impacted by weight other than those listed here and that are improved by treatment of weight. But just to give a sense of how much weight do people need to lose in order to see these benefits, this slide shows that for some conditions like diabetes and dyslipidemia, even a very modest 3% weight loss can have a significant impact on health. Other conditions, it might be more in the 5 to 10% range. And for many conditions, what we know and what the evidence shows is that the more excess weight a patient loses, the more benefits they obtain as far as decreasing symptoms such as those in sleep apnea or arthritis, and improving outcomes in conditions like diabetes, fatty liver disease, polycystic ovarian disease, and even things like cancer. The foundation of weight management really is a multidisciplinary team. This is not work that we can do alone, but it requires the whole team, which is what health centers do so great. So everything from our medical assistants to medical providers, clearly registered dietitians, and our community health workers, maybe outside collaborators like bariatric surgeons, fitness professionals, really the whole gamut of our medical teams and our community health center teams are necessary in order to do this work. So what are the core therapeutic options? Of course, everyone's familiar with the idea of lifestyle change. That is the basis for weight management and a very important aspect, which I'll be talking about more in future slides. Also, behavioral programs. So giving patients the tools that they need to manage their weight over their lifetime, really working on goals and long-term strategies. And then, of course, there are pharmacologic therapies and both medical devices and surgery. And I'll talk about all of these more. So the general recommendations among multiple specialty organizations for the treatment of overweight and obesity, again, lifestyle is foundational no matter what level of weight people are at as they're starting this journey. Pharmacotherapy is indicated for people with a BMI 27 to 30 and comorbid conditions, or for people with a BMI of 30 and greater with or without comorbidities. Endoscopy is not commonly used at this time, but can be indicated for people with a BMI of 30 or greater. And surgery is indicated for people with comorbid conditions and a BMI of 35 to 40, or for people without comorbidities with a BMI greater than 40. Okay, and next I'd like to talk about the interventions that we're using clinically. In this slide, you can see on the left-hand side that as we go up the pyramid, the treatment intensity is increasing. So more invasive treatment, treatment that takes more effort as well. And so that's indicated for people with higher levels of adiposity and risk for the adiposity-related chronic conditions. Starting at the bottom of this pyramid, we see the lifestyle modifications. And we know that these are really foundational to all of our treatments, that it's very important to address physical activity, nutrition, sleep, stress, all of these things, and including sometimes prescriptive nutritional interventions that are offered to manage this. However, we know that these generally result in either weight maintenance or up to a 5% weight loss. And often those benefits decrease over time, that perhaps somebody loses weight initially with their lifestyle efforts, but over time regains and sometimes gains above their baseline. So while these are very, very important, regardless of our treatment, often they're not enough on their own. What they are beneficial for is weight maintenance, which is often really undervalued in our society, but maintenance is so important. It can really, over a lifetime, have a tremendous impact. But for many people, they need more than just the lifestyle interventions. And in this case, pharmacotherapy can add another 5 to 20% weight loss. And this is indicated for anyone with a BMI greater than 27 and an obesity associated condition, or a BMI greater than 30. Endoscopic procedures are not commonly used at this time. However, we'll probably see a lot more of them in the future. And they can result in varying amounts of weight loss, but up to 20% for endoscopic gastric sleeve. And then higher up on the pyramid here, we see surgery in yellow, which is associated with a weight loss generally of 20 to 40%. Most commonly, about 30% from the patient's maximum is achieved a year after surgery. And that over time, people tend to trend up in weight a bit, and by 5 years out, end up about 20% below their maximum weight. This is indicated for anyone with a BMI greater than 35 and an obesity based medical condition, or with a BMI greater than 40. And in many cases, we often use surgery plus medications. So we know that after people go through the initial weight loss that first year, that many people start having a gradual return of hunger and cravings. And prior to having people regain a lot of their weight, it can be beneficial to add pharmacotherapy to help them maintain or lose a little bit more. And this is similar to what we do for many other conditions, such as breast cancer, where somebody might have surgery and they also often are also on tamoxifen. So it's not unusual to combine the two approaches. So now talk a little bit about lifestyle changes. What kind of lifestyle changes are we recommending? So the left three boxes here are the things we commonly hear, right? Daily monitoring of food take and physical activity, tracking, reducing portion sizes, and decreasing overall calorie counts. These things can be beneficial. We know that in the short term, they can help with weight loss, but they often are not sustainable due to the metabolic adaptation of the body and decreases in metabolic rates as people start cutting calories, as well as increase in hunger hormones. And so this is where if people start having the increased hunger, increased cravings, that it can really be beneficial to add medications in order to help people to be able to maintain these lifestyle efforts. Also, we do have to be somewhat nuanced around recommendations for frequent monitoring. That for some people, that can be very effective and very motivating. But for other people, it can really lead them down the pathway of putting too much focus on this area of their life at the expense of their overall well being, and that it can lead down the pathway of worsening or possibly provoking eating disorder behavior. So we do have to be somewhat nuanced on that. Stress management is very important. We know that if people are stressed, it's going to be harder for them to adhere to lifestyle efforts, and also can increase stress hormones that can impact their ability to manage their weight. Restful sleep of sufficient quantity is very important as well. Again, the lack of sleep can increase stress hormones that have a weight positive effect and also make it harder to adhere to lifestyle changes. And then with exercise, we know that any is better than none, and more is usually better than whatever people are doing. So generally, the recommendation is for 150 to 300 minutes of exercise a week. For behavioral health programs, again, it's really a broad approach that we know that behavioral health support for lifestyle changes can be very beneficial. Tools and supports such as apps and text reminders, food diaries, things like that can be helpful, exercise videos. Counseling and therapy can be very important for managing the many complexities of people's lives and how that impacts their daily behavior, and really dealing with some of the underlying chronic problems that may be impacting their lifestyle and their health. We also know that for behavioral health programs to be effective, that most studies show that really at least 6 to 12 months and probably even longer of support is beneficial. Also very difficult to achieve. Behavior change, again, monitoring and stimulus control, working with patients around how to manage different social interactions that impact their food intake and their physical activity can be helpful. And then ongoing feedback and accountability. Again, with nuance. For most people, this can be very helpful with frequent weighing, peer support groups, tracking. But for some people, this can be an added stress and can exacerbate problems rather than making them better. So next I'm going to talk about pharmacologic interventions. So the good news is that we have an increasing number of medications that we can use to help people manage their weight, and they are becoming increasingly effective. When I think about medications for patients, We know that all of them are contraindicated during pregnancy and breastfeeding. So if I have a patient with a uterus of reproductive age, that's always my first approach, is to talk to them about their pregnancy intentions and make sure that if they are going to take these medications, that they are not at risk of pregnancy. All of the weight management medications are also contraindicated with the co-administration of monoamine oxidase inhibitors within the previous 14 days. So orlistat is an old medication, not commonly used at this point, although it is sometimes recommended by insurance companies as a first step. It has a lot of potential adverse effects, mainly around GI symptoms, fecal soiling, and greasy stools. Not something that I use a lot due to these side effects. Phentermine is another medication. It's been around since 1959. We have a lot of safety data on it. So from a safety perspective, I think it has the highest safety of all of our medications because we know the most about it on a population level. Contraindications are glaucoma and hyperactive hyperthyroidism. Phentermine and topiramate has been on the market since 2012. The contraindications to it are glaucoma and active hyperthyroidism, similar to phentermine. Naltrexone and bupropion have also been approved for weight since 2014, and both of those medications were in wide use prior to that. They cannot be used with somebody who is actively on opioids or is in acute opioid withdrawal or with uncontrolled hypertension because it can increase blood pressure. Also is not to be used with people with a seizure disorder, bulimia, or anorexia, and caution with concomitant abrupt discontinuation of alcohol, benzos, barbiturates, and anti-seizure medications. The newer medications include the GLP-1 agonists and tirzepatide, which is one medication that has dual mechanisms, both GLP-1 and GIP. Setmelanotide is a separate agent which is indicated only for patients with rare genetic conditions that lead to obesity, such as POMC deficiency. This is not in common use, very, very expensive, but I think is very interesting for the future medications in that it's targeted to specific genetic defects, and we'll probably see more understanding of these type of mechanisms in the future. The GLP-1s are contraindicated for anyone with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia, and there are cautions around a history of pancreatitis. This slide shows where in the body the different medications work, and it's very interesting to see that aside from orlistat, which only works in the gut, that all of the others work in the brain, and they really impact the very complicated physiologic processes that impact hunger and cravings. So here's a list of the adverse events of the different medications. I won't go through all of these. Orlistat, really not sustainable for use over the long run due to the associated adverse effects. Phentermine and topiramate, generally well tolerated for most people. The most common side effects I see are paresthesias, and so I often warn people that they might feel some numbness and tingling in their fingers and toes as they start the medication. Generally, that goes away with time. So if they know that it's something to tolerate for a while, it tends to go away. Of course, not everyone gets it, but some people do. If it continues to be bothersome, it is reversible when they stop the medication. The most common reason for stopping is topiramate can be associated with a fuzzy thinking, cloudy head, as people describe it, and that's usually the most common reason it might not be tolerated. Naltrexone and bupropion, generally pretty well tolerated, of course, can have a number of side effects as listed here. And then the GLP-1s and the tirzepatide can cause a multitude of GI symptoms. Everyone has heard about this in the media. But for most people, they're well tolerated as long as they're titrated slowly. So I always talk to people as I start these medications and let them know that if they do experience these side effects, that what they should do is go down to a lower dose first and take longer before titrating up. That with proper titration, most of these problems can really be avoided or minimized. And this slide shows a general algorithm for thinking about which anti-obesity medications to use. So as I think about this, first I want to make sure somebody is a good candidate. I make sure that they are at a BMI and comorbidities, which is indicated. So again, greater than 27 with comorbidities or greater than 30 without comorbidities. And then I think about safety. All of the medications are safe that I've mentioned here. And I think about their contraindications. So do they have seizure disorder, glaucoma, hyperthyroidism, pancreatitis, family history or personal history of medullary thyroid carcinoma, or multiple endocrine neoplasia. So depending on which of those contraindications they might have, I would rule out certain medications. From there, I think about what are their associated medical conditions. If they have diabetes, as you'll see on this algorithm to the left, or cardiovascular disease, then I really think of starting with a GLP-1, since that will also treat the diabetes. If they have depression, I might think about bupropion, especially if they're already on another antidepressant that may cause weight gain, possibly thinking about changing the weight-inducing medication for bupropion and naltrexone. Do they have alcohol use disorder? In that case, naltrexone might be a great avenue to pursue. Or do they have something like pancreatitis that would be a contraindication? In that case, I would not want to use a GLP-1. For fatty liver disease, we know that the GLP-1s have the most evidence around improving the liver function and can be effective in greatly decreasing steatosis and may have an impact on fibrosis. That's still unclear exactly. And for obstructive sleep apnea, we have new evidence that tirzepatide can be beneficial. And again, we know that the GLP-1s or any weight loss can be beneficial as well. Then for uncontrolled hyperthyroidism or hypertension, we would want to avoid agents with bupropion and make sure that hypertension is controlled before starting phentermine as well. And in thinking about medications, aside from the comorbid conditions, I also think it's very important to think about cost and accessibility. We know everybody is wanting the newer agents that are highly advertised and also highly effective. But for most people at this time, the cost is extremely prohibitive. And always want to think about adherence for the long run. Again, since these medications only work while patients are taking them, adherence is very important. So we want ideally medications that have few to no side effects for an individual and that are easy to take. The weekly dosing, of course, being easiest, and daily easier than BID dosing. So next I'm going to talk about starting the medications. One thing is not to require patients to make lifestyle changes prior to starting medications. That's something I commonly hear from people, that we really should be requiring that. But I think just like with many other medications, we wouldn't wait for the patient to make changes before getting people to goal. So, and a great example is hypertension. We don't require people to eat a low salt diet prior to starting an antihypertensive medication. Of course, we encourage that and we want them to do that, and we will work with them over time using motivational interviewing to optimize their lifestyle efforts. But we also don't hold back what we know to be effective therapies. So really doing both at the same time can be very motivating, getting people those early wins of successful weight loss and working with them on lifestyle. I also really want to point out to patients right from the start that obesity is a chronic condition and that the medications are very helpful, but they only work while they're being taken. And so they need to be taken chronically, and that they only work a certain amount. So most people want more weight loss than they will get with medications. And so I try to give people realistic expectations and let them know that when they do achieve that expectation, that that is a success, that that's beneficial for their health, and that it's important to continue that medication in order to continue that level of benefit. And then also recognizing that not all medications work for all people. And so we don't want people taking medication that's not effective. So if the 5% weight loss is not achieved, then making sure to circle back, see if the patient's actually taking the medication, troubleshoot any difficulties they're having, and then considering either increasing the dose or stopping that medication and trying a different agent. And then, of course, we always have to document our obesity treatment plans, just like with any condition. So the insurance coders always want us to make sure that we're documenting both the obesity class and the BMI. So those are important parts of our documentation. I think it's very important to clearly document the patient's maximum weight historically that they've had, because that, even though they might be at a lower weight now, their body is always trying to get them back to that maximum weight. So that's an important consideration. Also documenting any previous interventions and what impact those have had. Had they been effective? Did they stop due to some side effect? And did they have any other adverse effects? And then what are their goals? What were their behavior goals? What's the long-term plan for their pharmacotherapy? Are they thinking about bariatric surgery or working towards that? And then what labs and referrals are needed? And really, again, always take in mind to leverage that multidisciplinary team. And what is their anticipated follow-up? So I'm going to turn the talk over now to Holly Bryant, registered dietitian, who will be talking about finding success in obesity care.
Thank you very much, Dr. Mockvi. So I am Holly Bryant. I'm the Registered Dietitian Director for El Rio Health, which is a federally qualified healthcare center in Tucson, Arizona. I am also a certified diabetes care and education specialist, and have been working in diabetes and obesity care for many years in many different environment. So I've been with El Rio for the past 10 years, and I've also worked for a native tribe here in Tucson, Arizona called the Pascoyaqui tribe. I worked for their health department. All right, so I will be presenting on finding success in obesity care. So why does therapeutic inertia exist around obesity and obesity care? There's probably a lot of reasons. It's complex, and our health system really, clinicians have to do a lot in a very short period of time. So oftentimes clinicians are busy and managing multiple complex chronic diseases. So obesity often in and of itself is not something that's able to be addressed in the clinic appointment. Clinicians may lack comfort in prescribing weight loss interventions, how to bring it up, how to discuss it with the patient. It's a very fast moving industry right now, so there's a lot to keep up to date on. So there may just be a lack of comfort in talking about that in detail. There also may be misconceptions around pharmacologic treatment. So, oftentimes there may be some thoughts that the medication is less effective than the lifestyle medication, modification programs, or, lifestyle behavior modification. There may be confusion about if the weight loss medications are safe or not. And there's some thoughts that it may only be for short term. So talking about some barriers to receiving care and the effects of weight stigma in medical care. So weight stigma is an independent health risk factor, even when controlling for BMI. So experiencing weight stigma can have negative consequences on health outcomes at all weights. There is reduced engagement in health behaviors. So patients that experience weight stigma report that they're less likely to engage in healthy behaviors or to engage in behavior change. It just feels inaccessible. It can feel inaccessible. And reduced engagement in healthcare. So patients that experience weight stigma at their healthcare appointment, they don't want to come back, or it's difficult, to get back through that door again when they've had that experience. And medical care is cited as the most frequent source of weight stigma. Interestingly enough, family is cited as the second most frequent source of weight stigma. So that can be a difficult environment for patients to come from, maybe experiencing weight stigma with their family or certain family members, and then coming into a healthcare appointment, maybe even coming into the healthcare appointment expecting to experience something along the lines of weight stigma, or unsure, or be fearful, or just the unknown. So that can also be a barrier for them to engage in discussing obesity management and having those conversations to really support them. So clinical gaps in obesity care can be another reason, there may not be success in programs. So there may be misconceptions about obesity. So a lack of recognizing it as a chronic disease and a relapsing disease in and of itself. Again, there may be associated stigma with obesity and talking about obesity. There may be treatment or therapy, needs to be, patient dependent. So there are barriers to care, clinical expertise again, and maybe access, patients getting access to a healthcare facility or a program that supports weight management. They may have experienced weight stigma and they don't want to engage with the healthcare system. Treatment accessibility. So yeah, where they live may be far from where there are programs available. There may be comorbidities to address. So lots of that complex chronic conditions that are adding to, the difficulty of getting care or having behavior change, really finding that inertia in behavior change. There also could be a lack of trauma-informed training from the medical care system and individual clinicians. And I will address that in a little bit later. And there could be challenges with pharmacological interventions. So cost is something that is changing every day. It seems like cost and insurance coverage. I've got a lot of patients that have been on medications for weight management for a year or 2 years, and they're getting a letter from their insurance that coverage will no longer be available. So a lot of people are scrambling to figure out, how can I afford this? Where can I afford this? So medication needs to be taken for life to maintain weight loss. So a lot of patients, even if they receive that instruction or that guidance, they may have other expectations or may have other thoughts or hopes about not being on the medication for life. So a lot of them think of it, I hear the term a lot from patients that it's a kickstart. They're going to jumpstart their weight loss with a medication, and then they hope to be off it within a few months or maybe a year. So there's a lot of discussions around that. The side effects and adverse reactions. The side effects, really, patients need a lot of support to problem solve around the side effects and the reactions. The nausea, sometimes vomiting, figuring out a meal plan or pattern that's going to work to support their energy and their activities of daily living throughout their day. And adherence. Again, if it's a daily medication or a daily injection versus weekly, where are the symptoms coming up? How, where do we store it? How difficult is it for them to have that daily routine? And then, there's structural and policy concerns. So there may be a lack of training, maybe the formal diagnosis or a management plan. There may not be that team-based care that some health structures are available for them, but in smaller clinics or rural areas, they really don't have that team-based care. There may be a lack of adequate facilities, and the social determinants of health is a really big issue where individuals, what is their transportation like? What is their housing like? What's their access to food? What is their job situation? Are they working 2 or 3 jobs and time is just an issue? I find that a lot with my patients. So addressing these gaps in care, it's really finding the resources that are in the community, and that could be really informal things, and really trying to match the interventions with the patients and what's going to work in their environment. And that may mean involving the family. It may mean involving other community-based organizations. Really researching treatments that have improved efficacy and safety profiles. So maybe figuring out what the barriers are on an individual level and finding that treatment that matches maybe the pattern of their life or their job schedule. If they work at nights, maybe having a different medication that is easier to take while they're sleeping or different things like that. Efforts to reduce health disparities by researching treatment responses in diverse populations. This is happening more and more. We're finding the research is, research teams are working to engage populations that we are all treating in federally qualified healthcare centers. Oftentimes that there is a research gap there with interventions in populations that are often underserved and have low resources. So really looking for that research that is highlighting those individuals and those communities' stories. connecting clinical providers with community programs and financial institutions that may be able to provide, they may already have a program going. The YMCA is partnering with a lot of agencies and organizations to have programs available for the public or at a reduced cost. And there may be financial institutions that can provide funding specifically for things to address SDOH. I can give an example, or I will give an example later when we're talking about the new market tax credits. El Rio took advantage of that, and we provide a food distribution at one of the clinics. So there may be some ways to provide support for addressing those SDOHs. And then improving access to care. So, looking at if there's availability for home-based care, if there's a mobile unit that can go out and provide care. And the World Health Organization really addresses the complexity of obesity management programs and how this really is intersectional and multidisciplinary. So the WHO has built a framework, and there's a link there if you're interested in reading more about that. And they do support that shift to more people-centered health services and involving really the community. So trying to work on multiple sectors of a person's environment. So involving the individuals, their family units, whatever that may be. Sometimes it's not biological family, but it could be friends and family. And then their communities, involving them all in their care. And then really having integrated health services that offer continuous care, including, prevention, diagnosis, treatment, management, rehabilitation, and palliative care. So really trying to address all of those levels of care. And I think the WHO does fall short. I think, working in an FQHC and working in different environments in the Southwest, I think oftentimes there is a component of capitalism and the structures of poverty that do make, sometimes epigenetics. So the obesity genes, or in creating environments where obesity is increased, the risk of obesity is increasing, and making it difficult to address or attend obesity management programs, which is time. If individuals are caring for family members, working multiple jobs, doing both, all of the above, having time to set aside to go to a program or go to appointments that are focused on behavior change can be really difficult, can be energy expended that they don't maybe have reserves for. So the WHO outlines a model of care for prevention and management of obesity. So again, all of those levels of care, primary, secondary, tertiary, but then underneath that pyramid, also addressing policies, integrating food and physical activity systems and built environment systems, looking at the national health system and design, context, and conditions. So again, our healthcare system is, we all have to do a lot with a very short amount of time and not a lot of resources. And some of that is kind of top-down structures. And then maybe involving technology. So again, that's another really fast-moving industry that is really changing how we provide healthcare. Telehealth is a great example. COVID really pushed that to the forefront. And I know my practice as a registered dietitian has completely changed. Most of my appointments are actually telehealth, which is really helpful because I can see their built environment. Sometimes I can see their kitchen and what utilities they're working with. So it's really benefited a lot of my appointments. So working with all of those factors when thinking about the management of obesity and developing programs or engaging with different programs. Some examples of obesity-related programs in the U.S. The Health Food Financing Initiative is a USDA program that provides loans, grants, and technical assistance to improve and support access to fresh, healthy, and affordable food in urban and rural underserved communities. I can give an example of this. At El Rio, we are partnering with an organization that has some of this money from the USDA to provide a CSA model produce for El Rio patients. The New Market Tax Credit is another example that incentivizes community development and economic growth through the use of tax credits that attract private investment to distressed communities. Again, another example, El Rio took advantage of this when they were building a new clinic. We provided space and a partnership with the food bank to provide a food distribution at that clinic site, which is an underserved population as far as access to produce. And then there's lots of programs under the Federal Hunger and Nutrition Assistance, so WIC, school child nutrition programs, so getting meals at school, especially breakfast is a really important one. I'm always happy when there's families engaging with that program. SNAP, and then nutrition incentive programs. The diabetes prevention program is a Medicare supported program, so it's focused on older adults and it's focused on pre-diabetes. So it is really capturing that population where obesity management does have a big impact on their chronic disease outcomes. It is Medicare supported, but I know in my community, this is offered to lots of individuals that have pre-diabetes. It's not age dependent. And then lots of communities have the double up food bucks at farmers markets. So take a look in your community and see if this is something that either your food bank may be the host of this, or if there's a farmers market organization, they may be the host for this. And this is really just individuals with SNAP benefits can go to a farmers market and get double the money. So they can turn it in, they can spend $10 and get a $20 coin or whatever they're using at the farmers market to then spend at that farmers market. So that's really popular. So just a little bit about that trauma-informed care and addressing that, that can sometimes be a barrier to patients receiving care. And when there is trauma-informed care embedded individually for clinicians, but also for systems, when the healthcare system is really addressing this from, top down and bottom up, it really does change the environment that the patient is walking into. And when they're receiving trauma-informed care from multiple modalities or multiple disciplines within the healthcare facility, it just really, buffers them and lifts them up to feel confident that they will be taken care of in a way that feels safe for them. And trauma-informed care really shifts the focus from what's wrong with you to what's happened to you, and how do we need to adapt to help you in this situation. So the principles of trauma-informed care are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. Well, some of this I would say is done on the back end, just kind of researching and reading and embodying some of that into your appointments. And then the other half of it is really communication, how you're communicating to the patient and asking for consent and collaboration with the patient. Some examples of this, in nutrition and physical activity advice, because often I think that's the quick advice that gets thrown out in a very short period of time in appointments. And sometimes is good and sometimes can be uninformed and may cause undue harm. Of course, we want the best and we give advice with the best intentions. But if we don't know what we don't know as far as what the patient may be coming from. So there's, with trauma-informed care, there's this window of tolerance, which is the zone in which the patient can readily receive, process, and hopefully integrate information and respond without too much difficulty. And a lot of the finding that window of tolerance can be communicated, or you can just kind of view what's the body language. Are they kind of turning away? Are they turning down? Or are they open and smiling and engaging? Does it seem like they're receiving the advice? And, asking permission is now a good time, or would you like advice on that? What are the goals you'd like to work on? And really creating that environment of safety. So staying present, that idea of active listening. There's kind of, a lot of things happening in our brain when we are with patients trying to address a lot of things that are going on. But asking a few questions maybe about their daily schedule or their meal pattern or what's their work schedule or their sleep schedule, even just one of those things can give you a lot of information about what that patient may be, what their life may be like. And really asking from a state of curiosity, so that I use that word a lot. I'm curious if you notice changes in your behavior, your eating, or your sleeping when example A happens, or when you're stressed. So, framing observations from a point of curiosity can help draw more out and help the patient feel safe. So it's not confrontational. And the check-in, after giving advice, does that feel okay? Or is that landing well? Or does it feel doable? Or is there something else you'd like to talk about or address as far as, your health goals for this visit? So it takes a little practice. I think a lot of us are very much well on the way of integrating a lot of trauma-informed care in our practice. So I'm just really happy to see more and more of that. So thank you so much for listening. And now I'll pass it on to Dr. Graham.
All right. Thank you so much, Holly. Some really great information being presented today. So today, in this section, we're going to talk about working with your patients. My name is Dawn Graham. I come to you from Ohio University Heritage College of Osteopathic Medicine. I'm a psychologist by training and have been practicing off and on for the last 25 years. Right now, I work with medical students and teach them how the mind and the body are connected. My primary interests are in rural health, global health, and community health work. So we're going to talk a little bit about behavioral strategies working with patients who have obesity issues. So starting off, we're going to think about using first person language. So language matters, and it matters a lot in a great deal when you're talking with patients because it's a sign of respect and it's modeling that language for your colleagues, incorporating that language that's more respectful, because it's really important to talk about patients as a patient with obesity, not an obese patient. We say the same thing for other issues such as diabetes. We don't talk about somebody as a diabetic. We talk them about a patient with diabetes. The same thing that goes with obesity, a patient with obesity. Their struggles are not their sole identity. So it's really important to be mindful of the language that we use. Strategies for engaging patients are entirely important. Your environment matters. It's really important to also incorporate supplies that are flexible, that are inclusive, high capacity chairs in your waiting rooms, bariatric chairs when possible, pedestal toilets, just like an ADA accessibility program. You want to make sure that the equipment and your furniture are able to be inclusive of your patient population. You also want to make sure that not only are you yourself as a healthcare provider educated with engaging strategies, but your staff as well. It doesn't do you any good if you have all the education about working with folks who struggle with obesity and the front desk staff is disrespectful or dismissive. So it's really important that the strategies for engaging patient are very much an office-wide incorporation. Motivational interviewing. This is a very important strategy in using health communication with your patients. Motivational interviewing is a health communication strategy that focuses on the patient as the agent of change. So you really want to be clear with them about the goals of behavior change that they come up with, not that you as the healthcare provider. It's a shared decision-making process. You need to be willing to start over. I'm not going to read this slide to you, but there's 5 A's in methods of behavioral change. You're basically kind of the assistant in helping the patient to figure out strategies to start to decrease their obesity. It's a very complicated process, as we already know. It's, not only their nutritional value, perhaps they're working with diabetes and other chronic healthcare conditions, but they're also working on behavioral health strategies such as sedentary lifestyle. So small movement, and there's other strategies that we can use that we'll talk about here in a moment. But motivational interviewing can be a really effective tool in helping people to make behavioral health changes. In the same vein, it's really important as practitioners to be aware of our unconscious biases. So do we have implicit bias against people who are of larger size? We want to focus on their health rather than their weight. The feedback that we give them, along with motivational interviewing strategies, should be non-judgmental in nature. We need to be we need to have a curious mind. One of the things that can be very destructive is if, as healthcare practitioners, we come in with the idea that the patient ought to change or they should change. It really isn't about us or what we think should happen. It's about the strategies that they think that will be most effective for their own behavior change. We have to be very aware of our unconscious bias and consider the fact that a lot of our patients have had unfortunate histories from other providers or that they've had biases from the public. They've been given messages verbally or non-verbally about the way that they should look or the way that they should behave. So just being aware of those things can be really helpful in helping the patient address behavior change. Reframing the conversations about obesity. Again, language matters. Seeking permission about what you need to ask for. Not taking the paternalistic approach that, traditional medicine has had, but really saying, can we talk about your weight? Are you at a place where you think we can talk about these things and strategies that might work for you? Using first person language, individuals with higher weight, individuals with a higher BMI, rather than labeling obese children or fat people. Using evidence-based information is always the really great go-to. Having, two or three really nice, solid statistics in your back pocket can be super helpful in helping to, tell the patient that it's not just your opinion or the opinion of those around them why they need to maybe, decrease their caloric intake or increase their lifestyle, their exercise behaviors. But also, this is why evidence has shown that X, Y, and Z. Having those statistics in your back pocket can be really effective in helping to help the patient solidify why the changes are being made, the ones that you're suggesting. There are preferred terms to discussing obesity, going from least motivating to most motivating, talking about unhealthy weight rather than being fat, or being overweight rather than chubby. There's blaming and stigmatizing that are deeply ingrained in the way that we talk about obesity, morbidly obese, which, kind of conjures up the idea of death. And that really isn't helpful in behavior change. So we want to talk about weight and high BMI. Weight is something separate from the patient. It's not a character flaw. It's not a laziness factor. We really need to create a safe, inclusive environment in which to help motivate our patients. And finally, considerations for shared decision making. Remember that you are part of a healthcare team. You also have to know the resources around you. If the patient is coming in and they might have accessibility issues that are related to social determinants of health, such as transportation issues or access to fresh fruit and vegetables, knowing the strategies, knowing the resources around you is super important to help, have a full, well-rounded approach to the patient, approach to change. So knowing your medical social worker, having a registered dietitian or a nutritionist in your Rolodex or your contact list can be super helpful, because the meta message there is that the patient understands that you are working together as a team. Using that shared language, such, let's work on this together. Let's think about a strategy. And when you come back to see me, if that doesn't work, let's try plan B. Being willing and open to change as a provider can be super important to be empowering and helpful in patient behavior change. So with that, I'm going to pass it back to Dr. Brar. Thank you so much for your time and attention, and I hope to see you again.
Key takeaways from our discussion today include obesity is influenced by non-modifiable risk factors and modifiable risk factors. Barriers to care can be addressed by tailoring interventions to match patients to treatments, using treatments with improved efficacy and safety profiles, connecting clinical providers with community programs and financial institutions, and improving access to care. Effective obesity treatment involves collaboration with professionals in nutrition, behavior, and physical activity. Clinicians can integrate motivational interviewing to encourage healthy eating and active living habits for achieving and maintaining healthy weight. Thank you for participating in weight management and community health, bridging systems and care coordination activity today. Please remember to fill out your evaluation to claim your CME credit.